A hiatal hernia is a stomach hernia. It's essentially when part of your stomach that's supposed to be in your belly slips up into your chest. It's a pretty rare problem, and thankfully, most people with this type of hernia do not need surgery. Really, only if it's a very large one or it's symptomatic do we recommend surgery in these situations. And the symptoms are almost always either acid reflux or dysphagia. And dysphagia means like difficulty swallowing. You feel like food's getting stuck here, usually in the part of your chest where the stomach is sucked up into. And so it's hard for the food that's going down into your esophagus, into your stomach, and then has to make its way through the defect in your diaphragm again. So it's essentially either reflux that's really bad or dysphagia where you have trouble swallowing food. Common type of this hernia, 95% of people have this type. It's called a sliding type hiatal hernia, and that's when just a little bit of that bottom part of your esophagus is sucked up into your chest, and the stomach is mostly all in the correct position in the stomach. And that can really just give you reflux. We only do surgery in that situation if your reflux is so bad that it's not adequately treated with acid reflux medicines, and two, if you just don't want to take those medicines for life, you can have the surgery to have that fixed. And a hiatal hernia can be diagnosed either on an EGD, which is an upper endoscopy, where a GI doctor goes in your mouth and your throat with a camera, or with a CT scan. The more common type of hiatal hernia that I fix is one of the larger types of hiatal hernias, like a type 3 or 4 hiatal hernia, when there's a good amount or the entire stomach up in your chest. And in addition to the reflux and the difficulty swallowing, these patients are a little more predisposed to the stomach twisting or volvulizing inside your chest. And that could be a surgical emergency. And that's why we recommend fixing the majority of those type 3 and 4 larger hiatal hernias. And hiatal hernias are tough. It's not like a standard abdominal wall or a groin hernia. We're trying to essentially pull the stomach back down into the chest, into the belly where it's supposed to be. We have to mobilize the esophagus, meaning like we have to get extra length on the esophagus. If we don't do that, then the stomach will just slip right back up into the chest once we're done. We have to close the hole in your diaphragm that your stomach is going through. It's called the esophageal hiatus. That's why it's called a hiatal hernia, because it's the hiatus of the esophagus that the stomach is coming up through. And then we have to wrap the stomach partially around the bottom part of the esophagus to recreate an anti-reflux valve so you don't have bad acid reflux after the surgery. And this surgery is a little bit higher stakes because there's a lot of really important stuff in and around where this surgery is happening. Your heart's right above us, your aorta is right below us. If you make a hole in the esophagus, that's a big deal. And in general, the complication rate of this surgery is very low. A significant complication only happens in 1% to 2% of patients. But when they happen, they can affect your life in a significant way. And that's why when we do surgery like this, we want to make sure we're doing it for a good reason. In today's day and age, this surgery is almost always done minimally invasively, or either laparoscopic or robotic. I have a strong preference toward robotic surgery. I just feel more comfortable